because we have to start. But you can send text message, WhatsApp message, or voice notes to 0703 1756537 or 08155917917. Okay, we're going to get into it. Dr. Collins, what is secondary infertility?
Okay, so basically, secondary infertility simply means the difficulty in a woman or for a couple to achieve conception after having had a child, okay, in the past. So just to give it a lot more context, the difficulty in achieving conception in a couple that already has a child, okay, despite having unprotected intercourse for 1 year or 6 months if the woman is above the age of 35 years of age.
Right.
Okay. Yes. So we've seen that this is quite prevalent even around the world. And basically in Nigeria, we see secondary infertility in about 50% of the cases of infertility of couples that come into the clinic for fertility consultation. Yes,
Mhm.
50% of the cases, in fact, around 53%, just to make it a little bit more specific. So it's slightly even, you tend to see secondary infertility cases even more than people who have never, ever been pregnant.
Right.
Oh, yes. So basically, there are some reasons for that. Usually, age and some other factors contribute to the reason why we experience secondary, why women or even couples generally experience secondary infertility. For some people, it is quite a strange conversation to discuss because they have certain school of thoughts in their heads that, okay, well, once I've already gotten pregnant before, so it shouldn't be difficult again, but it is never the case. It's not always that case. For some people, they have it easy. They get pregnant, first child, 2 years later, the next child, some other person, even 1 year. That is the child spacing that they do every 1 year. After 1 year, they get pregnant again for the next child. But for some other persons, it doesn't work that way. So while certain people do not get pregnant at all, that is primary infertility. Some other
Mm.
persons, they get pregnant, have the first child, okay, and after that, they do not get pregnant again. For some people, even secondary infertility also encompasses people that have gotten pregnant, even
Right.
though they didn't have the child. So, irrespective of the outcome of that pregnancy, as far as they've gotten pregnant before, okay, and after that, they started finding it difficult to conceive. That is still secondary infertility.
Hmm.
Yeah.
Okay. Okay. So why is it different to primary infertility?
All right. So in primary infertility, the woman has they've never had a child. They've never
Mm-hmm.
had any pregnancy. There's
Mm-hmm.
been no pregnancy and there's been no child. So, okay, yeah, so that's in the case of primary infertility, where the couple have been trying for a year, or when the woman is under the age of 35, or 6 months, when
Yeah.
the woman is above the age of 35, despite all the unprotected intercourse and all, there's been no pregnancy. So
Mm-hmm.
there's like absence of pregnancy entirely. So that is primary infertility. But for secondary infertility, okay, the woman maybe has gotten pregnant before, or she even has a child before, okay? And after that, it has become difficult for her to conceive. So that is now secondary infertility. And
Mm.
this, like I said, secondary infertility would happen because certain things do not remain constant in the body. And one of these things is fertility. The fertility of a man or a woman does not remain constant. Like we will say, previous fertility does not guarantee future pregnancies. Yes, I might have been pregnant in the past. I have even 5 children from a previous, maybe before, or maybe from even a previous marriage, and then now you remarry again, or even with the same spouse, you now start to experience difficulty while trying for the sixth one. That in itself now is secondary. Perfect.
Okay.
Okay.
Okay. Thank you so much for that, Doctor. And so, what Dr. Collins has said is that just because you've had a child before doesn't mean that you automatically get pregnant again. I suppose this is for men and for women, because for women this is it. For men, because you hear of cases where the man says, "Oh, but I had a child when I was 20 or something, when I was like university."
Yeah.
That is not always the case, right?
Yeah, so it also applies to both genders, be it male and female. So that's why sometimes when defining secondary infertility, we prefer to use the word couples. Okay, it goes both ways. But sometimes when you use couples, it throws a little bit of vagueness, so to say, to the expression. So that's why sometimes we just say, okay, women. But after a while, we'll tell you that, of course, so the man's side is also not to be excluded. So it goes
Yeah.
both ways.
Both ways. Okay. Now, my next question is, how common is secondary infertility, especially for couples that, like we said earlier, didn't have any difficulty or any weight in conceiving their first child?
Okay. So yeah, so basically, like I said earlier, about 40 to 50%, okay,
Mhm.
of the fertility consultations in the clinic, okay, usually borders around secondary infertility. So we tend to see it a lot more often. So if you sample about 10 cases of infertility, trust me, about five of them will be secondary infertility. The woman has either gotten pregnant in the past or she even
Mhm.
has a child. Yes, for some people, they got pregnant and then they had a miscarriage. And after that miscarriage,
That
it
was a
became very difficult for her to conceive. That has been the case. In fact, and this is even reflected in our practice. Like we can actually relate and reckon with these statistics. In Nigeria, the statistics show that around 50 to 53% of cases of infertility are actually secondary
Mhm.
infertility. So the woman has gotten pregnant before, they already even have a child before, and after we just started experiencing difficulty. So this is the
Mhm.
prevalence of the secondary infertility in the world and even in Nigeria.
Okay, so what are the most common causes of secondary infertility?
All right. So I'll start. Well, order. Specific order. Okay. I'll
Mhm.
just start from, and I'll just. So basically, the very first thing really is the advancing maternal age. So we usually tell women that as a woman advances in age, especially from the age of 30, the amount of eggs that she has, okay, starts to reduce. But it's not. It doesn't reduce to. It doesn't. The rate of reduction doesn't become significant from that age of 30
Right.
until she gets to the age of 35. So the reduction starts to increase in like it increases in rate. So
Mhm.
reduction in the egg quality and the quantity. Okay, these are two different discussions. So one talks about the number, one talks about the potency, the strength, the vitality, so to say, of the egg. And when we talk about the vitality of the egg, we're not talking about just the physical structure of the egg. We're also talking about the chromosomal integrity. Is the chromosome of the egg, the genetic component that carries the genetic information of the egg. Is it okay? Is it normal structurally? Is it normal numerically? Number one. So these are some of the things that you also want to talk about. So basically, as a woman advances in age, after the age of 35, from 35, it becomes very significant. Okay, so the reduction in the quality and the quantity of that. She got pregnant three times and had a miscarriage at about 8 weeks, 6 to 8 weeks. That was everything. So the moment she came into me, I just smiled because as she was talking, I didn't even need to do any investigation. I already knew
Mm.
what the problem was. Okay, so basically, these are some of these expressions that we see. So basically, that is not one of the first causes, the advancing maternal age. The next thing, of course, is diminishing egg reserve. This diminishing egg reserve is simply something that stems from the advancing age of the woman, like we
Okay.
said earlier. So where the egg quantity starts to reduce. But again, this can also be attributed to be what we call an ovulation factor. So as a woman
Right.
advances in age, the quality of our ovulation, okay, also changes, so
Change.
to say. Yes, exactly. And then some other conditions can also make it difficult for a woman to ovulate frequently, especially for women who have polycystic ovarian syndrome, primary ovarian insufficiency, so they don't get to ovulate often. As a result, it will result in, secondary infertility. Imagine a woman, because like I always tell clients that sometimes when PCOS, this condition, or what we call PMOS right now, once it wants to manifest its manifestations, so to say, it is as though you just switch on a switch, okay, in the house, like a room that has that is dark, and then you turn on the light, so to say, or a room that is lit, and then you turn off the light, and everywhere goes dark. So that is how it is. That is how it manifests. It just starts so abruptly. The woman has been seeing her menses regularly. All of a sudden, one day, menses disappears, comes back after 2 weeks. Before you know, it starts to grow all the acne, oily skin, and then things just start to change. Starts to add weight. Like it just starts abruptly. So that's how it is. So why I'm saying this because a woman out there might be listening to me who before she had after she had her first baby was when she was now told that she has polycystic ovarian syndrome. So
Yeah.
yes, for some people that is how it is. For some people, they had the PCOS diagnosis very early and it prevented them, and as a result, they were already aware from a long time. And of course, they've not been able to conceive or even up till now. But for some other persons, they had their first child, and then when they started trying for the second one, it became difficult. And then the doctor
Mhm.
said, "Madam, I'm sorry, you have PMOS or PCOS, as the case might be, and then and then she becomes surprised. So again, diminished ovarian reserve is the second thing. The third factor is tubal factor. So we've seen that women experience secondary infertility because of tubal problems, and these tubal problems they express themselves in the form of salpingitis, hydrosalpinx. Hydrosalpinx is where there's fluid accumulation inside of the tubes. So
Okay.
usually some of these things happen, and even some people might have tuber problems because of endometriosis. Okay, endometriosis can so that condition might be found inside of the tubes also, and can ultimately result in the obstruction of that tube. The next cause is endometriosis itself. Endometriosis is a condition where you find the tissues that should be found in the lining of the womb. You find it
Mhm.
outside in ectopic sites. You find it in the tubes. You find it in the pelvic cavity. You just find it in very abstract places. Okay, and this condition predisposes to chronic inflammation, adhesions formation. It distorts. It changes the way the organs are structured in the pelvis, in the pelvic cavity.
Okay.
Okay, so because of adhesions formation, it can bend the tube one way or the other, attach the ovaries. So it does a lot of architectural distortion. Okay,
Yeah.
in the pelvic cavity. So endometriosis can cause this. The next, of course, is the uterine factor. Okay, uterine factor in this case, we're talking about conditions like uterine fibroids, endometrial polyps, adenomyosis, uterine adhesions. For some people who have done maybe HSG and they said you have adhesions, or you've done hysteroscopy and the doctor told you that you had endometrial adhesions, or what we call Asherman syndrome. Okay,
Right.
so in this case, the moment you're saying that, that is a uterine factor that can predispose you to having a secondary infertility. And for some other factors are medical conditions like type 2 diabetes. In this case, we can also talk about hyperprolactinemia. We discussed this about a while ago on the program, where there's high level of prolactin in the body and it can
Yeah.
suppress, yes, can suppress ovulation. Again, we can also talk about hypothyroidism, where there's an underfunctioning thyroid gland. The thyroid gland is a small gland that's located in front of the neck. It acts as a powerhouse of the body. Truthfully, it regulates the way the body functions, producing
Okay.
energy and all of that. So again, it can also affect, it prevents a woman from conceiving after she has previously conceived. Can even be the reason why a woman can experience recurrent miscarriages and recurrent IVF failures. And the next cause that we want to talk about now is lifestyle factors. So lifestyle factors can prevent a woman from conceiving after she has conceived before, prevent a couple from conceiving. In this case, I've been using the word woman, but it's actually couples because it can also affect a man. A man who was not smoking before, or who maybe has been smoking, but it never affected his fertility. Okay, it never affected his
Right.
capacity to produce quality sperm. That same smoking can, of course, in the future, prevent the man from producing adequate sperms. Okay, resulting in oligospermia, poor sperm motility, and the rest. So smoking, alcohol intake, obesity, very high stress levels, lack of sleep, all of these can alter the way your body functions, and in turn would affect both sperm production and the quality of sperms, can also affect the way you prevent a woman from even ovulating, okay, and also affect the quality of the ovulation, or so to say. And then lastly, sorry, the next is unexplained infertility. Unexplained infertility is simply a condition that affects about 20% of couples worldwide, where if they have done all the investigations that they know to do. Every test comes out normal, but they are just not getting pregnant, despite doing everything right, having unprotected intercourse and all of that. But they are just not getting pregnant. Okay, remember, unexplained infertility also has its causes. We will leave that for another discussion, but it has its causes. And then, and then, like lastly, male factor. So the male factor, like we said, okay, that lifestyle could also predispose to is also a reason why a woman will find it, a couple will find it difficult to have their second baby. Okay, yes. So male factor in this case talks about sperm-related problems, low sperm counts, astenosospermia, teratosospermia, where the sperms have a lot of the quantity of cells that are abnormal are more than the ones that are normal, or maybe the sperms have become so slow, most of them are dead, they are not moving. All of this. Only active sperms can fertilize the eggs of women. So once a man already
Okay.
has a poor quality sperm that is reflected in poor motility, poor morphology, and all. Of course, it will affect and prevent their chance, or will limit the chance of the woman to conceive, for a second child, to have a second pregnancy. So basically, I've been able to go through about 9 causes, by all of these
Yeah.
explanations.
You mentioned the tubal, I think that was the third
Tubal
one.
factor,
And
yes,
yes, and endometriosis is part of it. What about uterine fibroids, PCOS, well, now
yes,
PMOS? How
yes.
do those do those conditions lead to secondary infertility? I suppose that a woman who has PCOS can have children, right? But then can it affect subsequent pregnancies? Even uterine fibroids as well, can it affect secondary infertility? What about infections that were not treated after childbirth? Can that
Beautiful.
also lead to secondary infertility?
Yes, so thank you for the specificity. So basically, polycystic ovarian syndrome, or PMOS, as it might be, of course, can actually result in secondary infertility. You know what PCOS does is that even though it has its tentacles in other systems of the body, cardiovascular system, and all the whatnots, basically what it does, it causes infrequent ovulation. It causes oligo ovulation. Okay,
Okay.
and can result in obesity, can even predispose to type 2 diabetes. All of these things would affect ovulation. So that is the end game, that the woman doesn't
Mm-hmm.
ovulate. So it can result in secondary infertility. So especially for a woman, like I said, like I did the instance earlier, that the woman who has conceived before and she didn't have that diagnosis, but when she started trying for the next child and it became more and more difficult, she was told that she has polycystic ovarian syndrome. Okay. Oh,
Mm-hmm.
yes. So basically, we've seen this kind of cases. And then, of course, talking about uterine fibroids. So uterine fibroids, they are simply those growths, those benign growths that grow in different locations of the uterus. So just for context, they can grow on the outside of the womb, they can grow in the muscle of the womb, and they can also grow inside the womb. The endometrial lining, that endometrium, that space where the baby is supposed to stay and grow until the baby is ready for delivery. So
Okay.
when you find a woman having a submucous fibroid, that is the fibroid that goes inside of the uterus. Okay, these fibroids, they pose a they can cause mechanical obstruction, so to say, okay, or mechanical interference. So they are found in the location where the embryo is supposed to implant and grow
Supposed
into
to
a
be.
baby. So as a result, they will prevent that embryo from finding a viable space to stay, implant, and grow. So that is how they cause that mechanical interference. They can also cause inflammation. They can also even be the reason why the tubes get blocked, especially if the woman has a very large size fibroid growing in the muscle of the womb, compressing on
Right.
a tube or compressing on both tubes, depending on the number of fibroids and depending on their sizes and their strategic location. Okay, so uterine fibroids can result in secondary infertility. And then you spoke about postpartum infections. Yes, during delivery, truthfully, there are processes and procedures that go on, and sometimes you cannot be too careful. Sometimes
Mm-hmm.
these infections can even be passed from physicians, or even or even maybe when the woman has even gone home. In the early phases where somebody is taking care of her and doing certain practices that are not hygienic, and as a result, she can, infections can spread from the vagina, the uterus, and into the tubes, and consequently result in a PID and all the whatnots that at the end of the day will not prevent the woman from conceiving, when attempting for a second child. So postpartum infections, yeah, it's also um, highlighted here as a cause, okay, of secondary infertility. And then you said one more thing again. I think you said so basically adhesions cannot be underspoken in this case, especially even in this case now for certain instrumentations that would have been done. Maybe for certain people, they usually have what we call retained placenta, okay, or retained products of conception, so to say, as the word is. Okay, so and then there are certain interventions, especially when you have repeated interventions to try to remove that retained products. Okay, you never can tell. Some of these repeated interventions can result in adhesions formation that on the long run, the woman might find it difficult to get pregnant. We've seen a woman who has done CS for her baby, and after the healing of the CS and all of that, found out that she had adhesions. Sometimes complications during child delivery can be the reason why the woman will not be able to conceive next time.
Yeah.
Okay. Oh,
Mm-hmm.
yes. So because of instrumentations and the rest, which of course are inevitable, truthfully. It's not like there's any other way to go about it. They are just instrumentations that would have, because at that moment, you just want to make sure that everything is done right so that the woman goes home in peace. Okay, so at the end of the day, do some of these instrumentations results in uterine adhesions on the long run. These adhesions become so extensive and that it prevents a woman from conceiving for a
Hmm.
second time. Okay.
More times 1 million. Oh boy, boy, boy. Okay. All right. So we've talked about what could cause other things that could cause, secondary infertility. You sort of like touched on, the male factor, but can you like spread it open for us? What else could cause infertility from the man? Is it a
All
case
right.
like a lot of men think that, oh, because I've given birth
Yes.
before, I give birth again. Can you speak to that, please? Thank you.
All right, thank you. So basically, so the male factor aspect cannot be understated as a cause of infertility generally. Okay, we live in a world that is sort of prejudicial when discussing male factor infertility. So men, can you hear me?
I can,
Okay,
yes.
okay, all right. That is sort of prejudicial or quite biased in their judgment when talking about male infertility, because we always think that male infertility, well, because it's just what most men the way they see themselves. They be like they be like, okay, yeah, yeah, I've had a child before. I even had 5 children from my previous marriage. I decided to just marry again because my wife nothing happened, and now they find it difficult to conceive, and now they find it difficult to impregnate a new wife, and then they be like, "It's the wife." No, it is not always so. So again, like I said earlier, male fertility now. Okay, so the fertility potential of a man also depreciates over time. We said that from the age of 45, the fertility of a man declines. So again, the
Okay.
sperm parameters decline. Okay, and when we talk about sperm parameters, it includes counts, it includes motility, it includes the morphology. Okay, so all of these declines, and there are certain factors, truthfully, that could cause this. The lifestyle of the man, smoking, alcohol intake, obesity. I mean, we've seen
Mhm.
obesity to be, especially for men, we've seen it as a sign of good living. But the truth is, it has its detrimental effects. It can reduce the testosterone level of a man and affect his capacity to be able to even achieve erection. For some people now, we've not even spoken to this. For some men, okay, the sperm is okay, but they're just unable to have erection. And this is actually stemming from the pot belly and all the whatnots now, reducing their testosterone level, reducing their libido. Okay. And again, for some people, previous poorly treated sexually transmitted infections can also damage the testicles, okay, can
Mm.
damage the epididymis, and as a result, the testis is not able to produce good quality sperms. For some other people, for some other persons, even these same sexually transmitted infections can result in obstruction, okay, along the path that should release the sperms. And as a result, the man would have what we call azoospermia. We've seen all forms of cases, okay? And so basically, it is important that men know that their fertility is not a constant. It is not constant K. Because you've had a child before doesn't mean you'll be able to impregnate another woman. Yes. Oh, yes. So it declines. And so that is the reason why it is important that when evaluating a woman for infertility, the man is also evaluated. I've seen now. This is just to throw in a little bit of. I usually try to throw in some of these stories. These are not just stories; they're actually physical experiences that I've had. Okay, of course, I can't tell another person's story. I can't tell, so, but I've seen a client. Okay, the woman came in. She's now currently, I think, 45, trying for a baby. We're not
Okay.
telling her that, okay, madam, okay, yes, these are your options here and there. She now said that they've been on this thing for like, I think, 20 years. And that the
Oh,
man, in that 20 years, the man only went to hospital once. And that was, I think, 3 years prior, where he was told that he has azoospermia. That all this while, he would say that that fertility, let me just use their word, fertility in a woman problem. That no, it's not a man's problem. And that the man would swear that that the only time he ever stepped foot into the hospital, he was diagnosed with azoospermia. In fact, the woman was literally very bitter. She was weeping while telling me the story. She was weeping. Literally, I felt her pain. Honestly, I felt her pain like on a very different level. I was like, wow, this is so painful. Can you imagine something that would have been attended to a long time
yeah.
ago? They came into the hospital at this time. The options would have been given to the woman might not even sit well with her. Well, for IVF, of course, it would come in for IVF because that is going to be the only modality that can get her pregnant at that particular age. And then even the kind or the type of IVF is the type that some people have their own reservations about. When we start to talk about use of donor eggs and the rest. Whereas if they've gone to the hospital at a very young age and they're diagnosed, maybe at the time, if they had even gone to the hospital, for instance, maybe 10 years prior, the man might even be having low sperm count, which is still okay for
Mm.
IVF. But when it has gotten to the point of hysterectomia, especially for people who have certain conditions like varicocele that can reduce the sperm of a man silently, okay? Such conditions, if they can be nipped in the bud, if they are diagnosed early enough.
Hey, man, help us to help you, please. Now, at this point, we're begging. At this point, we're begging. What's going on? Okay. So let's talk about treatment for a couple who now realizes that okay, there is secondary infertility going on here. What should be their first step of action?
All right, beautiful. So basically, the very first thing is if they have been trying for a while after having had a child or having had just a pregnancy in the past, would advise them to come in for evaluations. Usually starts from that point, the discussion, the consultations, and then the investigations. For the man, there are three tests basically. I wonder why men do not even go for tests, but there are just three tests that we really want to
Because
do.
they
You want
think
to do your
it's the woman's
it's a
problem. You said
woman's
it already.
problem, right? Yes, exactly. So, and they just three tests for the woman, for the man. The woman has to go through a lot of tests, but the man has to go through just three. And the three tests simply include the sperm analysis, a hormone profile if you suspect that there is some hormone problem going on, and that is the reason why the man is not having good quality sperm. Okay, you add a hormone profile to that. Okay, and then lastly, a testicular scan. Remember, I said that varicocele is a condition that can cause male factor infertility. It
Yeah.
affects the sperm
Mhm.
of a man. And varicocele is simply an enlarged vein in the testicles, which can be diagnosed largely through testicular or what we call a scrotal ultrasound scan. Once the scan is done, okay, to be able to see this varicocele, and then of course, will guide the man, to what next should be done, okay, for treatment. So just three tests for the man. Okay. For the woman, she has to do the hormone profile to check the hormones of the body, the AMH, okay, the FSH, LH, prolactin, and for some women that have polycystic ovarian syndrome, HSG or the ICOC. So the HSG would have to check whether the tubes are open or not, check for tuber patency. Okay. And then for others, of course, you also want to do what we call it's like a form of uterine cavity, the cavity that is the endometrium. You want to do an endometrial assessment. You want to scan that inside of the womb, okay, to check that just to be sure that there are no problems, there are no fibroids, polyps, adhesions. And the way you do this is by doing what we call hysteroscopy.
Okay.
Hysteroscopy is an investigation where you pass it's an instrument that has a camera, okay, into the womb, just to visually inspect everything to check whether there are polyps, fibroids, or adhesions. Okay, and then for some people, they might also need to do the sonohysterography. It's also a way to check that uterine cavity integrity, just to be sure that there are no problems in there. Okay, so there are still some additional tests, especially for some women that you may suspect might be having infertility because of immunity problems, like we call it immune infertility. Maybe you want to check for what we call antiphospholipid assays and the rest. Okay, so these are some extra investigations that can also be done. Okay, so these are
Mm.
the tests that should be done. So once these tests have been done, then we now go to treatment. The treatment would depend on the cause of the secondary infertility. So
Yeah.
for instance, if it is a tuber factor infertility, if secondary fertility is being caused by the tubes, for instance, by a tuber problem, okay, you want to counsel the clients to go for IVF, especially if both tubes are blocked. It's
Mhm.
IVF. If one tube is blocked and one is open, the woman can still continue, can still get pregnant truthfully, naturally even. Okay. But she has to know that her chances of getting pregnant naturally is reduced significantly because
Mm.
of only a unilateral tuber patency. Okay. If it's a uterine problem, if the problem is because of the uterus itself, maybe because the woman has fibroids, polyps, or adhesions, then she has to go for a hysteroscopic myomectomy or a hysteroscopic polypectomy or a hysteroscopic adesyolysis. Okay, that's to remove. These are simply procedures that are done to remove fibroids. That is just a grammar I just spoke now. Remove fibroids that are inside the womb. Remove polyps that are inside of the womb. Remove adhesions that are inside of the womb. Okay, and then for people that have fibroids that are not inside the womb but outside of the uterus, it is not everybody that has fibroids that are located outside that will require operative intervention.
Okay.
Okay, especially so basically, there are certain things we also want to check the fibroids for: the size, the location, okay, and the symptomatics, and also the age of the client. So if the fibroid is not big enough, there's no need to chasing it. If it's just a small intramural fibroid, meaning a fibroid that's located in the muscle of the womb, and it's not distorting the endometrium, it's not compressing on the endometrium, the inner lining of the womb, there's really no need to go and start pursuing it. Okay, or so like I said, the symptomatics also matter for people who bleed heavily during menses, or it's making them to just bleed haphazardly out of the blue. They just start to bleed when it's not even their menses. They have pelvic pain, maybe because the size of the fibroid is very large. Such persons would require operative intervention, of course. But like I said, just for emphasis, not everyone that has a fibroid that is located outside of the uterus would require intervention. If the
Mm.
case is maybe polycystic ovarian syndrome, then of course that can easily be managed by lifestyle optimization. Weight loss, change your diets, ensure a rich, well-balanced diet, reduce your carbohydrates and sugars, reduce your weight, ovulation induction using of medications, Clomid and the whatnot. Please, under the guidance of a doctor, of course,
Mhm.
it can help the woman to ovulate. Remember, I said that the problem with polycystic ovarian syndrome is that it causes infrequent ovulation, and that becomes the basis for which the woman will not get pregnant because she's not
Yeah.
ovulating regularly. Yeah, so once you take care of the things that should allow her to ovulate regularly and you induce the ovulation, she'll be able to release eggs and she can get pregnant. Okay, so that's for PCOS. For people that have other ovarian related causes of secondary infertility, like primary ovarian insufficiency, they might require IVF with the use of donor eggs in order to allow them get pregnant. Now, if it's for conditions that like endometriosis, the woman would require maybe laparoscopy to try to help her to reduce all those pains that she normally has and to clear out some of those endometriotic lesions. For some other people, if it is mild to moderate, if it is mild or minimal case of the endometriosis, simply a staging of the endometriosis, they would require ovulation induction. If it is moderate to severe form of the endometriosis, it is IVF. They should go do IVF. Okay. If the case now, I don't know if I've listed everything. If it's in a case of unexplained infertility, if the woman is under the age of 35, they can still do ovulation induction with timed intercourse. Okay, and IUI. If the woman is above the age of 35 but under the age of 40, they can still do even IUI, but preferably they should do IVF at that stage because they tried for too long. I mean, after the age of 35, like we said, the egg reduce in their quality and in their quantity significantly. So at that age, you want to hit the nail on the head. So, and one way to do that is to do IVF. Okay, so IVF is a better this thing. And then for people with, like I said, male factor, have we talked about male factor already? So for people with
Earlier
male,
on, yes, you
I
mentioned
talked
the
about it.
treatment.
Okay,
Yeah.
yes. So, but for
Or not the
treatment,
treatments.
not the treatment, good for the treatment of male factor infertility. Again, we want to introduce lifestyle modifications, like we said, about people that are obese and that have poor sperm qualities. Of course, they will try to optimize their weight, reduce their weight, try to get to normal BMI. Okay, that in itself would improve their testosterone level and production. And of course, it will improve sperm parameters, but it doesn't end there. Conditions like varicocele that causes silent reduction in sperm parameters, okay, even to the point where it starts from becoming low down to the point where it becomes zero entirely, where the man doesn't have sperms at all. These conditions, like I said, she require treatment like varicocelectomy. It is simply the removal of those varicocele, okay, in order to allow the testes to have normal blood flow and allow for good intratesticular temperature that will promote sperm production. Okay, so and then for some others, they might require again, what do you call it now? IUI if it is mild case of male infertility. And if despite all this intervention, the sperm parameters are still low, okay, they might need to resort to IVF in this case. And
Mm.
we also spoke about lifestyle modifications generally. It's usually the first point of call. But sometimes when you've already been able to diagnose a condition that is present in the couple, you just want to nip it in the bud hit the nail on the head straight, just direct the treatment towards that condition. So, but for lifestyle interventions, usually what we advise, stop smoking, stop drinking, optimize your weight by getting a normal body, a BMI. We're not saying that you should become from fat to becoming totally slim, but let your BMI become normal between 18 and at least 24.5. That is normal BMI. 24.9, I beg your pardon. That is a normal BMI. Okay. Yes. So let's come down to a normal BMI. And then, of course, or take a balanced diet. For women, they should start taking what you call supplements at least 3 months prior to when they want to actively start conceiving. So supplements should be part of the daily routine of a woman. Folic acid for people who do not want to just go overboard. But if financially you're capable, would advise you take more superior supplements like the fertility boost for him and for her. That has all we actually have it in our practice, what we currently use in our practice, having excellent results from this supplements intake. So you can take such supplements called like fertility boost for him and for her. You know, it's not quite expensive. It's not expensive actually, but the benefits are actually worthy of note really. And it's important just to take it out here. And what is the last thing now? Exercise daily. Okay, exercise regularly. Exercises are beneficial to both male and female. It helps the blood flow just the right way. It even helps to improve the sleep of certain people. Generally, we've seen cases like that. Okay, and then reduce stress levels. There are different ways to reduce stress levels. One of the easiest way to reduce stress level is to sleep. Yes, sleep at least 6 to 7 hours. Well, ideally we'll say 7 hours, but let's just reduce it because of Nigeria. We know truthfully there. So at least sleep minimum 6 to 7 hours, at least that will suffice. It just helps your body, function the right way, reduce your stress levels, and allow for ovulation and improved fertility outcomes.
Okay.
So, yeah,
There were two things that you said I wanted to ask. The first one was for the fibroids and the what was the second one? No, what was the second one? Was it endometriosis? I think I'm not even sure which one it was. But I wanted to ask for the fibroids, and I think we've had this conversation before. How
yeah.
soon can like they now start trying for a baby? I think the last time we had this conversation on fibroids, you said within 3 months, 6 months after the surgery has been done. I can't remember
Yeah.
the second one you mentioned. Was it endometriosis or was it PCOS? No, PCOS is lifestyle. It might have been endo. No, no, no.
Was this
The egg.
endometriosis?
No, the eggs. The egg donor. Yes, the egg donor. You had said
Okay.
that. So it's a case. So it's not that the woman cannot carry the baby. It's that there can be fertilization internally, right? So if you get donor eggs, that means that that's almost similar to IVF, isn't it? So the baby is fertilized and then put in the woman's body. So those are my
Okay.
two questions.
Okay, so the very first question, which is myomectomy, so you can start trying for a baby after 3 to 6 months. Well, some school of thought will say 3 months. Okay, well, personally, I say 3 months. Okay, after 3 months, the womb would have healed properly and should be ready for conception. Oh yes. So at least, but some other school of thought say 6 months. So we just keep it in the middle between 3 to 6 months after the myomectomy. Start attempting for conception. Start trying again. Okay, yes, start trying again. For some people, even they might be required to do myomectomy before they go in for their IVF. Usually, we see this kind of cases. Again, it's still the same thing. After your surgery, between 3 to 6 months, you come in. After the surgery, then you come in for the IVF procedure. Now, about the other one using donor eggs, I don't know. Maybe it is in relation to the primary ovarian insufficiency, where a woman's ovaries stop producing eggs before the age of 40. But in this case, usually we would require the woman to use donor eggs for IVF. So what is done is that for anybody coming in for IVF and you're told to use donor eggs, what is done is that we get a donor who usually is under the age of 30 and fulfills all the necessary criteria that has to be fulfilled. Okay. And of course, eggs are taken from such a lady or a young girl, and of course, inseminated with the partner's sperm. So the
Okay.
embryos that are formed, we will transfer back into the womb of the woman. Yes, so it is very different from surrogacy. Surrogacy, someone else helps the woman to carry the pregnancy. But for the use of donor eggs in IVF, okay, the woman will carry the embryo. So the embryo is transferred into the recipient,
Okay.
into the intending parent, not into a surrogate, but into the
Okay.
intending parent. Yes, so I don't know if that is the question here, because the only time I
Yeah,
touched
yeah, yeah.
donor egg was during the primary ovarian insufficiency or premature
Right.
ovarian failure discussion. Yes.
No, if it's surrogacy, that's even another conversation entirely. It's just that
Yeah.
I wanted clarity that it's not that the woman cannot carry a baby, is that the fertilization cannot happen inside of her.
Yes, yes, it is safe to say call it that. Okay, yes. Now, the reason simply is because she can no longer produce eggs. Like in that case of the client that I spoke about, for instance, at 45, coming in for IVF, and she was advised to go in for donor cycle IVF. Okay, so it is ideally if she was able to produce eggs, chances are excellent maybe fertilization can still happen inside of her. I mean, we've had people be around the age of 45 who still conceive naturally in the world today. Yes, we're not saying it's not an abstract finding. It still exists. But when you come in for IVF, we don't advise you use your own egg at the age of 45 because the quality of the egg that we produce at that age, okay, even if it gets fertilized, okay, might not result in a good quality embryo. Okay, you might not result in a quality in the formation of an embryo that is void of chromosomal anomalies. Okay, and this is the reason why we do not advise women at that age to consider using their own eggs. Yes, there are
Okay.
still some ways to try to improve the quality of egg in a woman, but the truth is, if you really do the analysis very well, the improvement is not so significant, truthfully. It's not so significant. So, but in that case, like I discussed now about that client, using donor eggs, she will still be able to carry the pregnancy. But
Right.
the egg that will be used is one that has a better chance of resulting in a good quality embryo that puts her
Mhm.
at pole position to conceive. Okay? Yes.
Okay. All
So,
right. Finally, before we go, Dr. Collins, my question is, because we have to like run, what's your final advice? What's the practical advice you can give to couples who already have one child but are struggling to conceive again? Maybe they're even losing hope. Yeah.
okay, so basically, the very first word I would say is that help is readily available. And so,
Okay.
prompt evaluation results in prompt intervention. Truthfully, that is how it is. You get over to the clinic on time, and then you get help on time. So, in
Mm-hmm.
this part of the world, we tend to always try other, what do you call it? You try to other interventions, other modalities before we now
Yeah.
finally come over to the clinic at the end of the time, at the time where water has passed Gary, so to say
Yeah.
in
Yeah.
quotes. So basically, my advice is that get prompt evaluation by your doctor. When you have tried for a year, if you're under the age of 35 as a woman and you're not getting pregnant, please drag your husband and yourself to the hospital. If you are above the age of 35, try for only 6 months. If it is not happening, please. And this also applies to whether you have had a child before. Or you guys have had maybe two different from maybe previous marriages, you've had 5 children each. It doesn't matter. As far as in this new marriage you've tried and you're not getting pregnant, please get to
Mm-hmm.
the hospital on time. And men should know that if infertility is not a woman's problem alone. We can't sound this enough. Some people, even in this 21st, they still believe that my mother never went to the, those kind of, I don't know, I don't want to, there's a word I'm trying not to use because I'm on air, So please get to the hospital, okay, with your wife. It's just part of the protocol, okay. It's important to achieve good results, in all. And last and okay, so just know that hope. Do not lose hope. That's my final message to couples. Do not lose hope. Okay, like I said, there's always help. If you get promptly evaluated, you get prompt intervention, irrespective of whatever model. In fact, for some people, they don't need to go. The decision that will be made for them will be still one that the one that will help them conceive. Okay, for some people, they're always scared that if I now finally go to the hospital, they will tell me to go and use donor eggs. No, not everybody will use donor eggs. Yes, there are people who are still conceivable naturally. This same one we've been preaching that at the age of 40, air quality would have been low. There are people still getting pregnant naturally at the age of 40, and they have the
Mm-hmm.
ability to show for it. So
Mm-hmm.
please, it's not like a one size fits all. So please visit your doctor and don't be scared. Okay, and there's hope, and
There
there's
is hope.
always
Thank you
intervention.
so much, Dr. Collins, for coming on the program today. Dr. Collins is the Assistant Medical Director and Fertility Physician at St. Ives Hospital, Specialist Hospital in Abeokuta. Again, thank you so much, Dr. Collins, for coming on the program today.
Thank
We
you
hope
for
to see
having me.
you
It's always a
again.
pleasure.
Yes.
Yeah.
Yes.
Soon. Soon.
All
Yeah.
righty. Take care. Enjoy the rest of your day.
All right. Yeah, bye.
This is still Women Radio 91.7 FM, and Radio Doctor is the program we just finished. Radio Doctor is broadcast on Women Radio Mondays through Fridays, 10 a.m. It is Nigeria's specialized radio health program. First free consultation in Nigeria, live on air. Join us tomorrow at 10 a.m. for another edition of Radio Doctor. Talk to you soon. Don't go anywhere. This is the Women Radio. We also have great music to keep you company. Do not go anywhere.